Welcome everyone to the Myasthenia Gravis Foundation of America 2019 series of webinars. We're pleased to have you all here this evening to join us. We'll give another minute or two for folks to dial in. As we're getting started, I just want to mention a few housekeeping notes. So we ask that you please either mute your phone or your computer. If you have both audio options enabled, it will disrupt the program and cause a lot of feedback, which will make it really tough for people to hear the presenter. We ask that you please hold your questions until the end to give ample time to the presenter to get through all of the material. And you can use the chat box feature located within the Adobe Connect system down here to put any of your questions into the chat box, and I'll take them throughout the presentation as well. And we do thank you so much for being part of this program, for taking time out of your evening, out of your day to listen to the presentation. So we're so proud to offer this program, which is Respiratory Issues and MG, as part of our 2019 series of webinars. We are pleased to present our speaker, Dr. Nicholas J. Silvestri. Dr. Silvestri is the Clinical Associate Professor of Neurology and the Assistant Dean for Graduate Medical Education at the Jacobs School of Medicine and Biomedical Sciences, University of Buffalo. He currently practices at Jacobs Neurological Institute and is affiliated with Kaleida Health Buffalo General Hospital. Dr. Silvestri accepts multiple insurance plans, including Aetna, MVP Health Plan, and Empire Blue Cross Blue Shield. Dr. Silvestri also practices at UBMD Neurology, Buffalo General Medical Center, the Muscular Dystrophy Association Clinic at BGMC, where he serves as co-director. Dr. Silvestri has specialized training in clinical neuromuscular medicine with expertise in clinical care and performing electrodiagnostic studies, nerve conduction, and electromyography. Dr. Silvestri conducts both clinical research studies and basic science research in collaboration with physician scientists from multiple disciplines, including neurology. His clinical research is focused on several studies that address illnesses such as Guillain-Barré syndrome, myasthenia gravis, and polyneuropathy. These studies include both treatment trials to find more effective treatments for these diseases, as well as research investigating the impact of diseases on patients' quality of life. So I'd just like to take this moment to please thank Dr. Silvestri for his time. And I'll do one more quick intro before we head over. And before we get started with the program, I would also like to thank our generous sponsors for the support of these educational webinars, which are noted here: Alexion, Momenta, RA Pharma, and also UCB Pharma. So I'll take this moment to turn it over to Dr. Silvestri so he can get started, and thank you again for joining us, and certainly any questions that you have or any issues, certainly pose them in the chat box and we'll get back to you as soon as we can.
Well, thank you very much for that kind introduction, and thank you for everyone for joining us this evening. Just going to go ahead and start the presentation at the very beginning. So I've been asked to speak about respiratory considerations in myasthenia gravis, and the talk itself won't take very long, and I purposely made it so that there are plenty of time for questions that may come up. So I'm more than happy to spend some time answering questions after the talk. So just speaking broadly about respiratory issues in myasthenia, fatigable weakness may involve really any muscle of the body in myasthenia, and certainly can involve the muscles of respiration. It's really not clear from the published literature exactly how many people with myasthenia actually experience respiratory issues, because the range of symptoms can be fairly broad, from mild shortness of breath with physical activity all the way to what we call myasthenic crisis. And we'll spend some time talking about myasthenic crisis in detail during this talk, because as I'm sure many people know in the audience, myasthenic crisis is basically defined as respiratory failure due to myasthenia. and is the ultimate form of respiratory dysfunction in myasthenia. So we have an idea of how many people may suffer crisis, but we don't really have a good idea of how many people have milder symptoms or even moderate symptoms, but we'll kind of talk through this throughout the course of the talk today. So I want to start, by talking about myasthenic crisis, because I think that lends to the discussion about kind of the broader topic of respiratory dysfunction and myasthenia, and frankly, respiratory dysfunction and neuromuscular disorders in general, of which myasthenia is a major neuromuscular disorder. As I mentioned, myasthenic crisis, strictly defined, is respiratory failure due to myasthenia. But it doesn't mean that just respiratory failure needing to be on a ventilator qualifies as myasthenia alone. Obviously, people that are having progressive weakness or progressive respiratory trouble that may lead to myasthenic crisis are also qualify as having crisis. And it may also be caused by what we call bulbar weakness. And so the bulbar muscles are the muscles that are largely responsible for speaking and swallowing. If people have such severe swallowing muscle dysfunction that the airway is unsafe, that people could potentially aspirate or put saliva or other contents from the food pipe, the esophagus, into the windpipe or the trachea, that could qualify as crisis as well. I said a minute ago that we don't really have a sense of how many people with myasthenia may have milder respiratory difficulty, but we do know that about 20% of patients with myasthenia will experience a crisis at some point in their disease state. We'll talk more about that in subsequent slides, but that's a pretty high number, about 1 in 5 patients experiencing crisis at some point during their course of the disease with myasthenia. It's more likely to occur a crisis, that is, within the first 3 years of the initial diagnosis of myasthenia. Myasthenia is it's an unusual disease in that in most people it tends to be more aggressive early in the disease course and less aggressive as time goes on, largely because of the treatment that we have. That's obviously a generalization. It's not always true. But in general, crisis is more likely to occur within the first 3 years of diagnosis. And it's the initial manifestation of the disease about 15% of the time. So up to 15% of patients have no signs or symptoms of myasthenia, and then all of a sudden they develop respiratory failure. And it's up to us as the docs in the hospital, when the patient's in the intensive care unit having difficulty breathing, to figure out that, in fact, it is myasthenia that is causing their symptoms, and obviously that needs to be diagnosed and treated appropriately. As many people in the audience probably know, myasthenia has a few causes. One of those causes is having acetylcholine receptor antibodies, but there's another type of myasthenia that has antibodies against what's called MuSK, and patients with MuSK antibodies are at a higher risk for developing crisis because of the higher likelihood of them having or experiencing problems with the swallowing muscles, or what we call bulbar dysfunction. So the diagnosis of myasthenic crisis is largely based on the history in the exam. And really what I mean by that is a patient with a history of myasthenia who develops progressive respiratory difficulty and has other signs of active myasthenia on exam, that makes the diagnosis of myasthenic crisis. I mentioned a minute ago, though, in 15% of people, the initial presentation of myasthenia may be a crisis, and in those situations, it's largely gathering the history from the patient or from family members about the symptoms that may have led to the respiratory dysfunction that may give us a clue that myasthenia may be the case. But in terms of figuring out if a patient with myasthenia, or any patient really, even if it's an undiagnosed patient with myasthenia, may be developing respiratory trouble, are what we call assessments of pulmonary function. And these aren't things that we can do just by looking at someone necessarily. These are tests, what we have here, as I've listed, negative inspiratory force and forced vital capacity. These are pulmonary function tests that we rely on our colleagues that are respiratory therapists to perform by using special tools. And there is a normal negative inspiratory force, which is a measure of how strong the chest muscles are. That should be above negative 80 centimeters of water, just for reference. And a forced vital capacity really is a measure of lung volume, and a normal forced vital capacity really is weight-based. So it should be greater than 50 cc's or 50 milliliters per kilogram of weight. So obviously a larger person would have a bigger FVC than a smaller person. So compared to what a normal value should be, we know if someone has a declining forced vital capacity or a forced vital capacity that's a smaller percentage of that predicted for a person's body weight, that can be a sign of impending respiratory failure and a sign of myasthenic crisis, and these are issues that we need to address. So just speaking more broadly, taking a step back from myasthenia specifically, and talking about respiratory failure and neuromuscular disorders. So these are, this next part of the discussion really would hold true for not only myasthenia, but also other neuromuscular disorders like ALS or Lou Gehrig's disease or muscular dystrophies and the like. But in general, in neuromuscular disorders, respiratory failure presents as what's called a restrictive pattern as opposed to an obstructive pattern. And basically what this means is that there's a difficulty with the chest wall expanding. It's not a problem with the lung itself. It's a problem with the muscles that really expand the chest wall and allow the lungs to inflate. And neuromuscular disorders, as listed on this slide, are certainly not the only causes of these problems. There are problems within the lung itself that can cause this. There's even problems with orthopedic issues. So if someone has what we call kyphoscoliosis and a twisted chest or a twisted chest cavity, that can lead to a reduced lung volume as well. All of these tests have to be put in the correct context. So what happens basically is that the muscles of respiration, the diaphragm, which is the big muscle that separates the chest from the abdomen inside the body, which inflates the lungs, but other muscles like the intercostal muscles or other accessory muscles, which are largely neck muscles, if these muscles are weak, it doesn't really allow the chest wall to open up. And what's called, it reduces what's called ventilation, or the ability of the lungs to take on oxygen and expel carbon dioxide, which is the main function of the lung. So an early finding is what we call orthopnea. Orthopnea is defined as shortness of breath when someone is lying flat. And so that's an early common finding because when someone is lying supine or flat on their back, gravity doesn't allow the diaphragm to be pulled down. So we're eliminating gravity, and what's pulling the diaphragm down is really the strength of the muscle itself. So that can be a common early finding. And then what we call hypercapnic respiratory failure, which is defined as, or which means really, is retaining of carbon dioxide because the lungs cannot inflate and then contract and get rid of the carbon dioxide. That results from progressive weakness. And this really is a later finding. If carbon dioxide is being retained by a person, it's a late finding, and it really signifies that there's impending true respiratory failure. But ultimately, not only is carbon dioxide built up, but oxygen is reduced as well, because what happens is that if the lungs can't inflate, the lungs kind of collapse down, what's called atelectasis, and it doesn't allow for the proper exchange of carbon dioxide and oxygen. And so when this happens, it's obviously a true crisis. It's a true medical emergency. And if that's not identified and treated quickly, and treatment is mechanical ventilation or artificial ventilation, there can be very negative consequences. So obviously, there's a range of symptoms and a range of signs, and in some patients, respiratory failure develops quickly, and in others, it develops more slowly. And when it develops slowly, we often have these early signs or symptoms here that I've listed. So if someone has chronic or early respiratory failure, people can experience non-restorative sleep and daytime fatigue, difficulty concentrating during the day, shortness of breath when bending over, again putting the diaphragm at a mechanical disadvantage, orthopnea, again, which is shortness of breath when lying flat, frequent throat clearing. This can again be reflective of having weak muscles in the throat and the voice box, which leads to possible aspiration, chest rattle, which basically is, it can be due to a number of different factors, but it can be due to difficulty clearing out secretions from the lungs, frequent coughing with meals, and a breathy voice. Later on, as this continues, as these symptoms continue, if they're untreated, impaired concentration can lead to frank confusion. So as carbon dioxide builds up in the body, it impairs brain function and people can feel quite confused. People can start to feel shortness of breath with even minimal exertion. And another sign is recurrent pneumonia. So if people have trouble clearing their secretions and secretions kind of filter into the lungs, over time that fluid can become infected and cause pneumonia. So these are some late findings of respiratory failure due to neuromuscular problems. This slide just basically kind of outlines a lot of what I just said, but basically respiratory failure in neuromuscular disorders is due to both inspiratory muscle weakness, so trouble expanding the lungs and taking a breath in, expiratory muscle weakness or having difficulty with lung recoil and actually clearing things out, and then bulbar muscle weakness. Again, we've talked about bulbar muscles being the throat muscles and the voice box muscles. All of these factors can lead to trouble inflating the lungs, trouble with coughing, and trouble with upper airways, which again can lead to ventilatory failure, pneumonia, and as well as sleep disordered breathing. So how can we predict respiratory failure? So in other words, what I mean by this slide is there a way for us as doctors, or is there a way for patients to tell their doctors when they might be entering kind of a danger zone in terms of going from maybe having mild shortness of breath to having more severe respiratory muscle weakness, which might be the sign of an impending crisis or problem, if people experience the rapid progression of weakness. So what I mean by that is one day a person's doing fairly well or has a baseline level of weakness, and then over the course of a day or so has a profound decline, has a profound worsening of their weakness for one reason or another. We often say that if the neck flexor muscles, the muscles that allow us to bring our chin down to our chest like so, if those muscles become weak because they share a similar innervation, those muscles share a similar innervation as the diaphragm. If those muscles become weak, that's often a sign of impending respiratory failure. If people can't complete or converse rather in complete sentences because they feel short of breath when talking, that's obviously a danger sign. If people use what we call the accessory muscles, so the accessory muscles are largely neck muscles that allow us to breathe in certain circumstances. If there's a use of the accessory muscles, if we see people's necks flaring when they're trying to breathe, that's a sign of impending respiratory failure. Tachypnea, which is rapid breathing, that's another sign, as well as these parameters down here that I talked about before, the negative inspiratory force and the forced vital capacity. If we're worried about someone's breathing, especially someone with a neuromuscular disorder, we'll often do these tests at the bedside to kind of get a sense of where a person stands in terms of their ability to breathe. This, again, is just a chart showing, some of the PFTs or pulmonary function tests that we look at when we're concerned about someone's breathing. These just kind of give you a sense of what normal is. So, for example, in vital capacity, which is a sign of a lung volume or a normal lung volume, a normal vital capacity is about 50 or 60 milliliters per kilogram. When someone has a reduced forced vital capacity to, let's say, less than 20 milliliters per kilogram, that's a sign that someone may need to be intubated and be mechanically ventilated in order to protect their airway while treatment can be instituted. So just shifting back to myasthenic crisis specifically, in a large study of myasthenic crisis done a few years ago, in this particular case series, the cause for crisis was identifiable about 3/4 of the time. Infection was the most common cause, but another illness or surgery, as well as trauma, stress, and certain medications were also causes. It's also important to know, and many people know this, that about 10% of patients that are put on high-dose steroids for treatment of myasthenia will initially worsen in the first week or so after they're started on high-dose steroids. What we mean by high dose, because that's obviously a relative term, is a dose that approximates about 1 milligram per kilogram of body weight per day. We think this happens because steroids in and of themselves have neuromuscular blocking properties, and before the immunological benefits of prednisone or steroids take effect in that first week, the neuromuscular blocking properties of the steroids may outweigh the immunologic benefits. So it's rare that a person who's not put on high-dose steroids is not hospitalized or at least monitored closely because of this known side effect. But the converse can happen too. Sometimes people have too aggressive weaning of their steroids, sometimes by their neurologist and sometimes by another doctor. And if this happens, that can also provoke myasthenic crisis too. So it's important that if you're on steroids for myasthenia gravis, that if that dose of steroid is really changed, it should be really under the direction of your neuromuscular or neurologist or your neurologist, because we're aware of these potential problems with steroids. So this is a short list of medications that can worsen myasthenia. This list is by no means exhaustive, but it's just, again, a caution, because in the previous slide I talked about how starting new medicines can actually provoke respiratory difficulties or provoke crisis. Those medications that are highlighted in bold are the medicines that are more likely, based on the literature and based on my experience, to cause crisis. But I always tell my patients that if another doctor wants to put you on a medicine, that's great. But if you could have that doctor give me a call, or if you could let me know before you do that, that would be fantastic, just so I can kind of weigh the risks and benefits of that medication, with you and with your doctor, so that we make sure that while we're treating one medical problem, we're not necessarily worsening another, and that is myasthenia. So just want a quick touch on cholinergic crisis, because anytime I give this talk to a group of doctors or patients, it comes up. So cholinergic crisis is pretty rare these days. Historically speaking, when pyridostigmine, which is mestinon, an acetylcholinesterase inhibitor, was the primary medicine used for myasthenia, and the doses that were used were relatively higher compared to what we use these days. This could happen, and basically what happens is if you give too much of these types of medications, it's almost like too much of a good thing. You stimulate the muscle so much that it doesn't want to move anymore. And so if you stimulate a muscle too much, and that muscle just happens to be a muscle important for breathing, that could paradoxically lead to difficulty breathing. Other signs of toxicity with these types of medications include excessive saliva and excessive tears, diarrhea, muscle cramping and twitching. But while I've definitely seen many cases of myasthenic crisis throughout my 10+ year career, I've actually never seen a case of cholinergic crisis. So it's rare, but it's something to be mindful of, especially if people are on relatively high doses of pyridostigmine. So how do we treat myasthenic crisis? Well, we protect the airway. So that usually means putting in an endotracheal tube or a breathing tube and ventilation. There are some studies, and I think I'll touch on one in a subsequent slide, of using BiPAP or non-invasive ventilation in myasthenic crisis. That has very limited data in the literature, and it can be helpful in a milder crisis, but oftentimes people need to be intubated. It's also, I recommend when people are intubated that we hold acetylcholinesterase medications like pyridostigmine, simply because, as I mentioned, that can cause too much saliva or too many secretions in the windpipe, in the trachea. And when that happens, it can be very difficult for doctors and nurses taking care of patients in the ICU to keep that airway clear. And truthfully, pyridostigmine alone doesn't often predict a successful wean. It's whatever other treatment we use, like let's say plasma exchange or IVIG, that gets people off a ventilator, not pyridostigmine. But as we're planning to get someone off of a ventilator, we can usually restart about a day or 24 hours or so ahead of time. But while someone's actually intubated, it's usually prudent to hold those medicines. And then obviously, if people have a feeding tube in, we can't feed someone. So NPO means basically no food by mouth. That also prevents aspiration. If someone is not frankly intubated and is trending that way, it's not a bad idea anyway. So as I mentioned a minute ago, in terms of using a less invasive method or what we call non-invasive ventilation or BiPAP, which many people with respiratory difficulty can use. It's actually also used for the treatment of sleep apnea. So there's a limited experience done in the Mayo Clinic in terms of looking if we can use BiPAP versus actually intubating people with myasthenic crisis. And it showed that in about half the patients in this study, arguably it was a small study, were treated with BiPAP for 24 hours. They were able to avoid intubation, but people with worse respiratory failure at the onset, which was evidenced by a higher concentration of carbon dioxide in their blood, which is what this number means here, that predicted failure. So if someone comes in early in myasthenic crisis, before the carbon dioxides had a chance to really build up, using BiPAP can be helpful. And in fact, I've done this in my own center, especially when it's patients that I know who come in. Often they'll call me, they'll say they're having trouble, we'll bring them into the hospital. And if we get them early enough, if we can get treatment instituted early enough, we can often use BiPAP as opposed to frankly intubating people. So how do we treat myasthenic crisis? Well, we really, try to find out what's causing it. I mentioned in a few slides ago that we can identify what the cause is about 70% of the time or so. If we find that someone has an infection, for example, we can, choose an antibiotic that won't necessarily worsen myasthenia, treat the infection, and therefore treat the crisis. But oftentimes, in conjunction with treating the cause of the crisis, we're also treating the immunological aspect of the crisis as well. And that's usually through plasmapheresis or plasma exchange, which filters out the antibodies, or a drug called IVIG or intravenous immunoglobulin, which again can be another effective treatment of myasthenic crisis. So usually when we treat the cause and then we treat the immunological aspect of the myasthenia, we're able to get people on their way to extubation and onto recovery. So again, in this study that I referenced previously from about 12 years ago now, in the series of patients with myasthenic crisis, the median duration, or how long people stayed in mechanically ventilated, was about 14 days. But it's important to know that a quarter of the patients were actually extubated, or the tube was taken out and they were able to breathe on their own after a week, and another quarter that were a little sicker and had a little bit more worsening respiratory failure were intubated for over a month. When this study looked at the predictors, older age, so an age above 50 years, tended to predict a longer course. Luckily, when it comes to crisis these days, the mortality is 5% or even less. And usually it's not due to myasthenia itself, it's usually due to a complication of often what got a person into myasthenic crisis. So, looking at this glass half full, people, survive in excess of 95% of the time with crisis. The mortality or people faring poorly in crisis is fairly rare with modern medical technology. So after a crisis, most patients are discharged on medications to control their disease, and obviously to control their disease and then reduce the future likelihood of a crisis. If my patients, for example, come out of the hospital after a crisis, we're seeing each other quite frequently, often every couple of weeks, until I'm convinced they're doing well or on their road to recovery. And as I mentioned earlier, the risk of crisis does tend to lessen with time. So the risk of a crisis tends to be, in most people, again, this is a very general statement, but in most people tends to be most common in the first 3 years after the initial onset of symptoms. But that's not obviously true for everyone. So again, I wanted to make the presentation kind of brief, and I'm glad I did that, because as I'm looking down at the chat, I do see some questions building up here. So maybe what I'll do is hopefully I've stimulated some discussion, and we can start addressing some of the questions that you've raised.
That sounds perfect. So I've made a note of the questions that have come through in the chat box, and certainly any other questions, please feel free to keep them coming, but I'll get started with what we have already. So a question that we have from Janet is, do you find that MG often gets misdiagnosed as asthma?
That's an excellent question. I think at the onset of symptoms, before a patient has more obvious signs of myasthenia, that it is often misdiagnosed, and it's often misdiagnosed as some form of lung dysfunction. I can definitely think of instances, over the past few years where people initially had a diagnosis of something like asthma or COPD as the putative cause of their symptoms. I can't really quote you from the literature a percentage of how often that happens, other than just to say that I've seen it myself. I know it happens, and I've seen myasthenia initially misdiagnosed as just about anything. So I think it's important, to kind of keep myasthenia in the back of our heads as doctors as a possible cause of symptoms. It's difficult for non-neurologists really to think about that, though, because a lot of times the only exposure to myasthenia that doctors have had other than neurologists are maybe in a lecture in medical school. While it's a difficult diagnosis to make, I definitely have seen people initially diagnosed with a lot of different things that ultimately was diagnosed as myasthenia as the cause for respiratory dysfunction.
Thank you so much. Another question that we have from Cheryl is, can you discuss bulbar weakness leading to upper airway dysfunction, not just swallowing, but weakness of muscles controlling vocal cords leading to stridor and or loss of airway?
Yeah, so right. So the bulbar muscles, again, just to kind of go back and address that. So really, the term bulbar comes from the brainstem, or the bulb of the brain, and what that really refers to are that the muscles that are important for speaking and swallowing and the like come directly off the brainstem, as opposed to the nerves for the rest of the body, which come off of the spinal cord. And so, so not only can bulbar muscle dysfunction cause swallowing trouble, which can then lead to things like aspiration and pneumonia, it can also lead to dysfunction of the vocal cords. The real job of the vocal cords actually is to prevent food or liquid from actually entering the windpipe. The secondary phenomenon that the vocal cords have in humans and in most animals really is to create sound, and so that allows us to speak. But yeah, bulbar dysfunction has many forms. It's not just swallowing dysfunction. Bulbar dysfunction can also lead to problems with the voice box, and that can either lead to stridor, which is a difficulty passing wind through the windpipe or the trachea. Can lead to speech difficulty, and it can lead to respiratory dysfunction in any number of ways that I mentioned.
Thank you. A question that we have from Nakava is, when doing Zumba or exercising, I tend to lose my breath and I feel like I'm hyperventilating. Could this be my myasthenia?
It could very well be myasthenia. As I mentioned, one of the, much like symptoms, any symptom of myasthenia can be worsened by physical activity. Respiratory dysfunction definitely can be provoked by exercise. So it certainly could be due to myasthenia. To kind of take the opposite point from an answer I gave to a previous question, while respiratory symptoms certainly can be due to myasthenia, they're not always due to myasthenia. So it's important to, have respiratory dysfunction evaluated by a doctor, because just because you have myasthenia doesn't mean you might not have another problem. And it turns out, actually apropos of the previous question, that one of the more common medical causes of difficulty breathing with exercise is asthma, for example. So that comes up again. Having one disease, unfortunately, doesn't protect you from having another. So to answer your question succinctly, sure, the symptoms definitely could be due to myasthenia. But I think it's important to make sure that you're evaluated by your doc to make sure that that's what's going on and nothing else, so that once that diagnosis is more honed, you can be treated.
Thank you so much. A question that we have from Janet is, what is the relationship to sleep apnea and MG respiratory issues?
Yeah, that's a great question. It's interesting. There wasn't much known about that particular question until a few years ago, and then one of my colleagues, Charles Kasarjian, who's actually at the University of Toronto, has done some research in this, and it turns out that that having sleep apnea is quite common in patients with myasthenia, and so it's very possible that there's an overlap here, and that having sleep apnea kind of feeds into this, and so. For most patients that I see with myasthenia, particularly if they have symptoms of fatigue or being very sleepy during the day, difficulty concentrating, some of the symptoms I mentioned in one of the slides that I showed previously, or sometimes breathlessness or morning headaches, I will get a sleep study to see if they may have sleep apnea, because there is, again, a higher risk in patients with myasthenia. And it turns out that treating that sleep apnea obviously often makes people feel quite better. And there are other medical consequences or health consequences of having sleep apnea. It puts people at a higher risk of other problems like heart attack and stroke and the like. So it's a very important diagnosis to make so that it can be treated, A, to make people feel better, but B, to prevent other health problems down the line.
Another question that we have through the chat box is, can anxiety trigger a myasthenic crisis?
Yes, I think it can. I don't have numbers as to how often that may happen, but I think anxiety or stressors. I think that I've definitely seen it trigger worsening myasthenia, either with or without respiratory dysfunction. So yes, I do think that that is a possible trigger. It's kind of a diagnosis of exclusion. So oftentimes when what I mean by that is oftentimes when that kind of comes into my head in a particular patient's case, I just like to make sure there's nothing else that could be contributing to it that we're not aware of. So for example, new medication, missed medication doses, underlying illness, that sort of thing. But yeah, that is possible.
Thank you so much. A question that we have from Craig, and he apologizes. He joined partway through, so he might have missed this early on in the presentation. But is there a typical way that a myasthenic crisis comes on? Is it gradual? Is it over a longer period of time, or is there not really a typical way that it comes on?
That's a great question, actually, and I'm not sure that I actually did adequately address that. So thank you for your question. I think the short answer is it's different in everyone. I've had some people, present in crisis or tell me later that they presented in crisis. They were fine earlier in the day, and by the end of the day, they were in the hospital on a ventilator. Oftentimes that occurs when people have an underlying infection and it really worsens things. But I have had other people who have had, kind of more low-level problems that kind of gradually built up over the course of days or weeks who eventually enter crisis. So, again, I think it's different for everyone. I'd say that of those two scenarios that I just mentioned, in my experience, the symptoms tend to be more rapidly progressive. It tends to occur over the course of a day or two, but that's obviously a generalization. I think that every possibility in terms of the tempo of the development of symptoms is possible.
A question that we have from Nancy is that she's had myasthenic crisis before, but her most recent one, she had spasming of the diaphragm and her throat was closing. Is this common? Does this happen often during myasthenic crisis?
I can't say that I've seen that very often. I mean, it's certainly a possibility. It's certainly been described. I mean, more often what happens is just kind of just progressive difficulty catching one's breath. But this almost spasm-like phenomenon has definitely been described. It's not entirely frequent, or very frequent rather, but I think it's been described by a minority of people that experience respiratory dysfunction, really of whatever cause. I don't think it's unique to myasthenia, but I think that it is a rare presentation.
Thank you. A question that we have from Daniel: if someone has signs of a crisis, but their NIF and their FVC tests come back normal, are there other ways that they could look for confirming the myasthenic crisis, other type of tests or things they could measure?
That's a great question. There are a lot of tests that we can use to measure how well someone breathes, but it turns out that the best tests and really the earliest tests that are affected in a possible impending crisis are the NIF and the FVC. So really, what I mean by that is if those tests are normal, the other tests that we may use, like blood work and whatnot, is almost never going to be abnormal. So I think in the cases where people have respiratory problems, they have clear symptoms of respiratory difficulty, but they have, at least at the onset, a normal NIF and FVC. Those are people that I often watch very closely because I tend to kind of listen to the symptoms that people are experiencing and pay close attention to that so that we don't miss something. But to answer your question more succinctly, no, if the FVC and the NIF are normal, I typically wouldn't order more diagnostic testing. I'd simply just watch someone. And perhaps repeat those tests at a given interval later.
Until next time.
And another question that we have from Bruce is that he's been told he has silent aspiration. Could this be due to my MG?
Yes. So silent aspiration basically is trace amounts of saliva going from the throat into the lungs, and so yes, that could certainly be due to a mild degree of what we call bulbar muscle dysfunction or swallowing muscle dysfunction or dysfunction of the voice box. So yes, that could definitely be due to myasthenia.
Okay, and I think we have a few more questions coming through the chat box. One question that we have, and MGFA does have some material on this, so I can also share that with you separately, is what should a caregiver do if somebody's in a myasthenic crisis after calling 911? What are some questions that a caregiver could ask or would do to advocate for that person?
Yeah, that's a great question, and I definitely think that I know what materials you're referring to, and I would certainly look at that material as well. But yeah, I mean, I think the most important thing is if someone's having trouble breathing, it's to get medical attention as quickly as possible, and so alerting EMS so that they can come and assess the situation as well. But I think once EMS arrives or the emergency medical technicians arrive, it's important to inform them that the person in crisis or with breathing difficulty has myasthenia. It's important to know that giving oxygen to someone with a neuromuscular respiratory problem is often not the best thing to do. Oxygen can be a good supplement, but it's not really an oxygenation problem. It's more of a problem with actually ventilating. And so, the ability of EMTs to be able to do something about that is variable from place to place. Oftentimes EMTs don't really want to necessarily have to intubate someone if they're not like actually in respiratory failure, which is probably a good thing. But I guess it would be important, let's say in the case of if someone had a BiPAP machine they're using, to have that kind of nearby. That might be a good supplement. But I think it's important to alert EMS as quickly as possible, to stay with that person, to alert EMS the patient or the person with the problem has myasthenia, and really to get into the emergency department as quickly as possible.
Okay, I think we have one more question, and then we can probably close on that. So a question that we have from Nancy is, after myasthenic crisis, you can have a slow recovery, but what things from a respiratory standpoint might be important to share with your neurologist other than normal shortness of breath?
I think that it's important for us to know, what types of activities you may have shortness of breath with. So If you're not having shortness of breath at rest, for example, how much activity can you do before you experience shortness of breath? What are the circumstances? In other words, are there specific activities or specific environmental circumstances that the shortness of breath occurs? What time of day does it occur? Are there other associated symptoms? And I think that allows us to be able to determine, is the shortness of breath actually from myasthenia? Is there something else going on? If it's from the myasthenia, what can we really do to try to maybe adjust medications or add therapy or order testing that might be necessary in order to help improve that? A good example is we talked about the association of sleep apnea and myasthenia a little while ago. Depending on what the answers to those questions were that I just mentioned, it may lead us to want to order a sleep study, for example, or if a person is taking pyridostigmine or Mestinon as part of their regimen, and a person is having shortness of breath at a specific time of day or under specific circumstances, perhaps the medication regimen can be adjusted to try to really minimize that symptom. So that's a great question, and I think that I outlined some important factors or other questions or other things to mention to your doctor to try to drill down into that a little bit more at your office visit.
Okay, and one more question that we're going through. I've been told that I've had many crisis scares over the years. I've been told never to allow the doctors to intubate me unless it is a last resort. Is this correct? Now, this may be specific to someone's situation, so that may be tough to answer this question.
Yeah, I think if that's the case, I would actually question, not in a negative way, but I would question the doctor why they said that, because as a general rule, again, not without getting into specifics of a particular person, as a general rule, that's not correct. Because if someone is in frank crisis, if a person with myasthenia is in frank crisis and has respiratory failure, then really the immediate treatment is intubation and ventilation. So there may be other circumstances at play in that particular case.
Okay, it looks like that wraps up all of our questions for now. I'm seeing that there is a lot of positive feedback. So some of the things that I'll just read back is that thanks for this presentation, great questions with clear answers. Even though I have been controlled for several years, I've learned quite a bit. A lot of great tips for people, especially when interacting with EMGs. So we're very thankful for your time and your insight and for answering the questions so thoroughly. So thank you so much, Dr. Silvestri.
Well, thank you, and thank you for having me. I appreciate everyone's attention.
So I'll take this one last opportunity just to thank our sponsors once again. Just our sponsors for underwriting these educational webinars and for allowing us to make these possible. And I'll do one additional plug for MGFA. So our annual conference, which is the only national conference for the MG community, will be taking place at the end of March through the beginning of April. So I'll share a link in the chat box. So if you'd like to learn more about the conference, what we have on the agenda, learn about our speakers, some of the activities that we have planned, certainly check it out. Feel free to visit. We'd love for you to register and join us if you can. It will take place in Atlanta this year. So thank you so much for your time. Thank you all for your great questions, your feedback. Thank you again to Dr. Silvestri for taking time out of his busy day to speak with us, and I hope you all have a wonderful evening.